So previously it was we saw the urinalysis of what happens to the urine and what kind of RBCs are present. Moving on to the serological evidence of streptococcal infection. So serologic evidence of streptococcal infection is present in most of the patients with pharyngitis. Okay, so like the person has history of sore throat, which is very important. And then, though antibiotic therapy may blunt this response, ASO titer is increased in more than 80% of the patients. Anti-DNase is elevated in case of streptococcal skin infection. So for a throat infection, ASO. For a skin infection, anti-DNase B. It's not A, it is anti-DNase B. So the titers decrease within 4 to 6 weeks. The level of serum C3 is low in 90% of the patients. Okay, anti-DNase, okay, ASO is elevated in 90% of the patients. C3 is low in, uh, anti-DNase கிடையாது. It is present in skin infection. Mostly it is the disease is following throat infection, pharyngitis. 80%, 80% of the cases ASO is elevated. 90% of the cases C3 is reduced, complement C3. The titer of anti-DNase ASO all normalize within 1 month or 1.5 months. The serum C3 normalizes is by 2 to 3 months. 1 to 1.5 months when the ASO anti-DNase. 2 to 3 months, that is 8 weeks to 12 weeks. 2 to 3 months when the C3 will become normal. Persistent low levels of C3 indicate other forms of glomerulonephritis. Moving on to the management. இப்போ வரைக்கும் வந்து we saw serological evidence, ASO, anti-DNase and C3. That is all. Management. Patients with oliguria and normal blood pressure can be managed at home. If it is mild oliguria, close attention to the blood pressure and dietary intake is necessary. Treatment with penicillin has no effect on the course of the disease but may be given if active pharyngitis or pyoderma is present. So only for the primary infection, so skin infection or the throat infection தான் penicillin கொடுப்பாங்க. It doesn't alter the course of the actual AGN. The principles of management of patients with severe oliguria and AKI are discussed later on. In the diet, diuretics, hypertension, left ventricular failure, prolonged oliguria. Okay, under these settings we will see the management. About the diet, the intake of sodium, potassium and the fluids is restricted until the blood levels of creatinine reduce and urine output increases. So we are waiting for the BUN-C to reduce and the urine to increase. So like the person has to pee normally. Overhydration may increase the risk of heart failure, hypertension. So overhydration. ஏற்கனவே the person is not peeing enough. So already there is hypervolemia. You don't want to give overhydration because it causes left ventricular failure. Patients with azotemia, BUN-C elevated, often require accurate measurement of urine output and daily weight and restriction of the fluid intake to an amount equal to insensible losses and 24 hours urine output. Okay, so the fluid intake should be reduced. The person க்கு வந்து daily urine output check பண்ணணும், daily weight check பண்ணணும், so that like in order to see how much the person is peeing. It's like kind of like an objective way, right? And then restriction of fluid has to be done, and then it should be restricted to such an amount that it should be less than the amount the person is peeing in a 24 hours along with insensible losses. So that's about the diet. All the sodium potassium fluids are restricted. Okay, diuretics. Patients show showing modest edema treated with oral furosemide 1 to 3 mg per kg. The edema disappears with the return of renal function. Therapy with IV furosemide 2 to 4 mg per kg is necessary in patients with pulmonary edema. Okay, so furosemide. Okay. Oral furosemide, IV furosemide. Oral furosemide வந்து எடிமாக்கு யூஸ் பண்ண 1 to 3 mg per kg. In case of pulmonary edema, we use 2 to 4 mg per kg IV furosemide. Okay. Oral furosemide for edema. For pulmonary edema alone, IV. Dose வந்து கொஞ்சம் அதிகம். In case of pulmonary. Moving on to hypertension. Mild hypertension can be controlled by salt water restriction. Effective antihypertensives include amlodipine, nifedipine, or diuretics. Beta blockers and ACE inhibitors carry a risk of hyperkalemia, so we don't want them. We use calcium channel blockers and diuretics. Patients with hypertensive emergencies need prompt treatment with IV